Hello, my name is Naval Daver. I'm a faculty in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. I focus on clinical trials with novel therapies and combinations, specifically immune therapies and novel molecular treatments in acute myeloid leukemia and myelodysplastic syndrome. Today, it's a pleasure for me to discuss the new treatment combinations that we hope will improve outcomes in patients with TP53 mutated acute myeloid leukemia. So as a background, TP53 acute myeloid leukemia is probably the most difficult type of acute myeloid leukemia. We see that almost all therapies have very limited activity. Historically, we did trials with intensive chemotherapy, cytarabine, anthracycline based, and all of these trials show that the remission rates were about 40 to 50% in TP53 mutated AML, but more depressingly, the median overall survival was between 6 and 8 months across all of these trials, with none of the regimens, 3+7, FLAG, IDA, CLIA, or others showing any significant improvement in survival in TP53 mutated AML. Recently, our group, led by Dr. Short, published an analysis of 200 plus patients with TP53 mutated AML treated on HMA-based regimens at MD Anderson or cytarabine-based regimens at MD Anderson in the last decade. And what was interesting to note is that with HMA-based therapies, the response rate, the CR/CRI rate, was maintained at between 50 to 60%, irrespective of the TP53 variant allele frequency. Patients with lower allele frequency, less than 20%, medium 20 to 40% and higher, had a similar response rate. However, with cytarabine-based therapies, we see a significant progressive drop in the remission rates as you go from lower to higher TP53 allelic frequencies, with remission rates of 60, 70% in low allelic burden, TP53 down to about 25, 30% in high allelic burden. And with additional analysis, we did identify that there could be a subset of patients who have low allelic burden, less than 40% TP53 VAF, without associated adverse cytogenetic abnormalities, and with only one TP53 mutation that could benefit from intensive cytarabine-based therapies. Now, mind you, this only makes up about 10 to 15% of all TP53 mutated AML. So it's a very small group, but an important one to identify, because this could be the one small subset in TP53 that can still have a curative outcome. But beyond that, we pretty much now agree that intensive chemo, HMA-based therapy, and recent data suggests even HMA venetoclax across the phase 1b, phase 3 study, and our MD Anderson decitabine 10-day venetoclax study, all has shown that the remission rates are about 50, 55% with HMA ven, but the median survival in all of these three separate analyses was about 6 to 7 months. So HMA venetoclax is not improving the outcomes in TP53 mutated AML much beyond what HMA alone did. So where do we go now? So there have been a lot of progress in different immune therapy approaches for AML, and a lot of focus of these immunotherapies is in the high-risk AML populations, where we now know cytotoxic, intensive chemo, cytarabine-based therapies, HMA-based therapies, HMA ven are not going to cut it and push the outcomes to the next level. Among immunotherapies, we're looking at two different approaches. One is antibody-based therapy, so antibody drug combinations, where we usually use a antigen-targeted antibody that is linked to a potent toxin, either bacterial toxin or chemical toxin, resulting in delivery of the toxin to the leukemic cell with cell death. This has been successfully done with drugs like gemtuzumab, which is approved in AML, and inotuzumab, which is approved in lymphoid malignancies. The second approach is to harness your own body's immune system to activate either T cells or macrophages or NK cells to fight against tumor. And there are different approaches being used to do this. For TP53 AML specifically, we are seeing encouraging single-arm data with a drug CD47 SIRP alpha antibody called magrolimab. The science here is basically that by blocking the interaction between CD47 on the surface of tumor cell and SIRP alpha on the surface of macrophages, we're removing the inhibitory signals on macrophages, resulting in the macrophages being unleashed. And once unleashed, they will attack the tumor cells. A lot of preclinical data has shown that this is a very, very relevant pathway and can be harnessed quite effectively, both in MDS and in AML. And now the clinical studies combining magrolimab with azacitidine are showing encouraging responses, with a total response rate of about 65% in all newly diagnosed older unfit AML, which is a little lower, but quite similar to HMA ven. But more importantly, in the TP53 mutated AML, we're seeing overall response rate of about 70% with a true CR rate of 45%. So this is really much better than what we have seen with any prior therapy for TP53. But again, single arm study, about 30 patients, and we're waiting for updated data that will hopefully be presented in the upcoming months. The median survival in TP53 mutated AML on this single arm analysis was about 12.5 to 13 months, which is actually better than what we have seen with any other regimens for TP53 mutated AML. So we're hoping that this regimen, the CD47 SIRP alpha inhibition, could be a very important pathway that works in TP53 mutated AML. We still don't understand clearly why. A lot of efforts with single cell RNA sequencing, as well as ATAC sequencing and cytokine profiling is ongoing at our institution and at others to try and understand what specifically in TP53 mutated AML makes it sensitive to the macrophage activation. And there are other CD47 SIRP alpha antibodies that are now entered clinic for AML, both for frontline AML, TP53 mutated AML, and relapsed AML. These include drugs like ALX148, Trillium TTI-622, lemzoparlimab, and even bispecific approaches to activate macrophages and T cells by leveraging both CD3 and CD47 SIRP alpha to try to get both innate and adaptive immune system activated, which could then have hopefully a double whammy effect against the AML. So these are all entering clinic, and we're excited to see what happens in the next couple of years with these different approaches. Another approach that was tried for TP53 mutated AML is a drug called APR, which actually enhanced P53 signaling directly within the cell nucleus. This was initially very promising with true CR rates close to 50% in 2 independent studies published in the JCO, and we were very hopeful that the phase 3 randomized study would show a clear benefit. Unfortunately, the primary endpoint, which was true CR rate, was not met by statistical analysis. However, we do see numerically the true CR rate was higher, 33 versus 22% for AZA APR versus AZA alone. So we still think there could be a benefit, but we have to go back to the drawing board and see what is the best way to implement the AZA APR in the optimal patients to harness the best benefit. And lastly, we're very, very excited about the emergence of cellular therapies. As many of you may know, cellular therapies have made groundbreaking breakthroughs in many different types of heme malignancies, lymphoma, ALL, as well as myeloma, showing very encouraging activity with different CAR-T, CAR-NK approaches. And we're starting to see some of the early signals of activity in AML with NK cell-based therapy, both high affinity, non-cleavable CD16 activated iPSC generated NK cells. So these are not CARs, but high volume NK cells. And some of the early data from a company, Fate Therapeutics, shows that these could be quite active in relapse refractory, low burden AML, and potentially we think in the future in lower burden disease as well. And also now NK CAR-T showing some early signals of response. And also for the first time, we're seeing a CAR-T cells directed towards CLL1, which I think may be a very, very good target in AML, in pediatric relapse AML, showing high response rates from a company, GZ Biogen, in China, and that study is moving into the adult setting as well. So I think with these cellular therapies, as well as the CD47 SIRP alpha, potentially some way to bring back APR and activating the innate and adaptive immune system, which is much less dependent on the molecular mutation profile, could be the path forward. And this is where a lot of our efforts and research, both at MD Anderson, my institution, as well as many institutions across the world, is moving to target this very, very difficult group. And lastly, if we are successful, I think we're doing some of the most intense research in TP53 mutated AML, but if we are successful in finding these, they could actually cascade into effective approaches for TP53 in other diseases, in lymphomas, myelomas, maybe even solid tumors. So exciting area of research, and hopefully some progress to come in the next few years. Thank you very much for listening.